Good afternoon, everyone, and thank you for joining us for today's webinar on identifying best practices for enhancing cultural competency in kidney disease. My name is Joy Hall, and I'm the Director of Outreach and Strategic Partnerships at American Kidney Fund. Today, I will be your moderator, where we will focus on cultural competency in kidney disease patient care with two nephrologists from institutions across the United States. Before I introduce today's speakers, I would like to take a moment to thank our sponsors listed on the screen. We're grateful for the sponsors and for their support of today's webinar and for their support of our Kidney Health for All program. This discussion on cultural competency is a part of AKF's commitment to raising awareness in the fight for equitable access, care, and treatment of kidney disease patients. For more information on AKF's Kidney Health for All program, please visit our website. On there, you'll find various downloadable resources for both you and your patients. So now, without further ado, allow me to introduce today's speakers. Our first speaker is Dr. Neil Powe. Dr. Powe is the Constance B. Wofsy Distinguished Professor and Vice Chair of Medicine at the University of California, San Francisco, and the Chair of Medicine at San Francisco General Hospital. Dr. Powe received the Herbert W. Nickens Award for promoting justice in medical education and health care equity from the Association of American Medical Colleges in 2023. In 2024, Dr. Powe was listed as Time Magazine's 100 Most Influential People in Health. Thank you for joining us today, Dr. Powe.
Thank you. It's a pleasure to be with you, Ms. Hall.
Wonderful. And we also have today Dr. Tessa Novick. Dr. Novick is a nephrologist and assistant professor for internal medicine at the University of Texas at Austin Dell Medical School. She is also the courtesy assistant professor in the Department of Health Social Work. Dr. Novick's primary clinical interest is caring for people with kidney disease who come from marginalized populations. Her research interests include disparities in kidney disease, social determinants of health, and improving care delivery of marginalized people with kidney disease. Thank you for joining us today, Dr. Novick.
Thank you so much for having me.
Wonderful. So today, we have our two speakers with us, and we're going to go ahead and get started with our discussion. So looking through the literature on the topic of cultural competency, there are multiple definitions. The National Medical Association defines cultural competency as the application of cultural knowledge, behaviors, interpersonal, and clinical skills that enhance a provider's effectiveness in managing patient care. I want to ask you both about how do you define cultural competency, and how has this combination of skills impacted your approach or insights on kidney disease patient care? So, Dr. Powe, how about we start with you?
Yeah, thanks, Ms. Hall. That's a wonderful definition, I think. That's the way I think about it. I think of it as cultural competence as kind of a set of behaviors, knowledge, and attitudes and policies that align and come together, whether in a system, an organization, or among professionals, that enables effective work in cross-cultural situations. And you can break that down as, when we talk about culture, we're talking about patterns of human behavior that are integrated, that includes language, thoughts, actions, customs, beliefs, and racial, ethnic, social, and religious groups. When we think about competence, that implies the capacity to function effectively as an individual or as an organization within the context of the cultural beliefs, practices, and needs that patients and their communities have. So, in essence, cultural competence in healthcare combines the tenets of patient and family-centered care with an understanding of the social and cultural influences that affect the quality of medical services and treatment. And as you know, with the increasing diversity of the population in the United States and strong evidence of racial and ethnic disparities in healthcare, it's critically important that healthcare professionals are educated specifically to address issues of culture. In addition to the National Medical Association, there's been bodies such as the National Academy of Sciences and Medicine and the American Medical Association have recognized the importance of cultural competence.
Wonderful. Thank you so much for sharing. Dr. Novick, I want to give you an opportunity to also share your thoughts on the definition of cultural competency and how you feel as though this has impacted the approach or insights on kidney disease patient care.
I actually prefer to think of it as more cultural curiosity than cultural competency. Competency implies that I know, or that providers know, can have the ability to know everything about, all cultures and other than their own. I work in the state of Texas, where we're not a Medicaid expansion state. We have a large population who is uninsured and underinsured, many of whom are immigrants who don't speak English. So my nephrology practice is actually in a federally qualified health center where I see predominantly Spanish-speaking individuals or people who are uninsured, lower income, and experiencing pretty large, substantial barriers to care, such as being unhoused. And my approach to cultural competency with all of my patients is understanding that what we are trained to do as physicians is very two-dimensional, diagnose and treat, medications, et cetera. But there is so much more that goes into what makes a human being human. And that is important to somebody. So, their family, their spirituality, their faith, their dietary preferences, their how they view medicine, how they view physicians, how, thinking about what they could potentially coming into the appointment with, preconceived notions, fears, motivator, different things like that. I think all of that goes into cultural competency and curiosity, and is something that we as physicians need to think about. So how that plays out with me is usually I ask a lot of questions, and I explain it as, I'm just trying to kind of get to know you. What are your goals? That sort of thing. Really, beyond, what's your blood pressure? What's your blood sugar? The kind of nitty gritty that we're trained to do. I think it's important to just get to know people as humans, understanding the different components of culture, again, that impact their health and well-being and how they view medical care. For my patients who are Hispanic, what I have learned, just another example, is their faith and natural remedies are very important to them. So kind of two components of culture that I try to think about and ask about. Faith and family, of course. So, and the way I not change, but kind of alter my practice is by encouraging them to bring their family to appointments, encouraging them to, think about if they need to pray about a decision, if they need to talk to their family, kind of encouraging kind of an inclusion of things that I, if I learn are important to them. And then same with natural remedies, there is kind of a preference for botanical ethnobotany in my patient population. And instead of just, disregarding it, I try to speak about it openly, and encourage it when I can, because I think it's a way of accepting accepting their culture. So, those are just concrete details or examples, but I would do the same for anybody. Just think about the different things that are important to them, um, and address it on a real patient level.
Understood. Thank you so much for sharing, both of you for sharing your thoughts on that definition there. So I want to kind of take a little bit of a turn and let's talk a little bit about cultural competency in the medical education space. So Dr. Powe, at the University of California, San Francisco, are there frameworks or performance measures that are or should be built into medical education programs to prepare future doctors and healthcare professionals for kidney disease patient care?
Absolutely. The faculty and students here must demonstrate an understanding of the manner in which people of diverse cultures and belief systems perceive health and illness. And they have to be ready to respond to their symptoms, diseases, and to provide treatment. And so at UCSF, we have a menu of educational options and opportunities for both our faculty and staff and students to engage in. They range from unconscious bias training. We have diversity and inclusion certification programs. We actually have an academy that aims to support diversity leaders and to teach people on equity inclusion, for which they can receive a certificate. We also have what we call DEI champion training and a variety of anti-racism resources, online DEI training, educational videos, and workshops. These all fundamentally work on a cognitive guide for deciphering cultural care from a holistic viewpoint of numerous aspects, as Dr. Novick said, that may impact care and people's well-being. The cultural component we often think is focusing on ethnicity, religion, healing practices and beliefs, which Dr. Novick talked about, and value orientations. A lot of these ideas come from many areas, not just medicine, anthropology, geography, sociology, economics, political sciences, nutrition, communication, family development, even social support theories. And so we try to bring all of that to our learners. The competency domains we concentrate on include knowledge, awareness, skill, and sensitivity. So there's cultural knowledge just about diversity, about what different groups, where their lived experiences have been. And then there's awareness and sensitivity, not only self-awareness, but situational awareness. For example, awareness of the influences that social cultural factors have on patients, clinicians, and the relationship, acceptance of their responsibility to understand the cultural aspects of health and illness, and the willingness to make clinical settings more accessible to patients. They have to recognize personal biases against people of different cultures. They have to respect and tolerate cultural differences. And we have to accept the responsibility to combat racism, classism, ageism, sexism, homophobia, and other kinds of biases and discrimination that occur in healthcare settings. One of the critical factors is actually providing communication skills. And as I said, using interactive educational methods, and then practical skills to extract impressions of sickness and health and treatment preferences from patients. cultural competence has to be part of all of clinical education rather than a single seminar that teaches facts about specific groups. So what we have people do is we continue this in skill-based time in inpatient units and outpatient clinics. So, whether you're talking about the care of a patient from a different culture or just one who doesn't share the Western biologic concept of illness, we have conversations during medical rounds, and they should incorporate the cultural background of patients as well as talking about the pathophysiology and treatment. And we give our learners direct feedback from faculty. I think also importantly is that physicians help as acting as role models, particularly minority physicians. And that has impacts on minority students who are considering a career in medicine, and helps us to attract a diverse student body. But I think one of the most important parts of this is having buy-in from the top leadership in our institutions. They have to make cultural competence a real science and develop a cadre of enthusiastic faculty. And that's what we try to do, is to develop diversity champions here at UCSF.
Wonderful. That sounds like a very thoughtful approach that you all have at UCSF. And, from there, I want to just kind of see if you, Dr. Novick, if you see any differences between UCSF's approach and also the approach that you see at University of Texas.
We have a pretty similar approach, to be honest. I think it's a top priority of the medical school to really train future physicians who are culturally competent, aware, and just competent in general. I will say I loved what Dr. Powe said about self-awareness and situational awareness. Two of the things that we also do here are incorporating a lot of self-reflection. I think that's one of the best ways to truly understand the influence of someone's culture, and to attempt to gain competence is to understand how your own background, skin color, religion, inherited everything impact how you think about things, your own experiences, your own traumas, how you deal with things, what you're bringing into the room, in addition to what the patient's bringing into the room. So we try to encourage and incorporate a lot of self-reflection after discussion of the different, components that influence how someone's health and well-being. But the situational awareness is also really critical. So Austin has, Texas in general has a pretty rocky history, and we continue to struggle with this topic. And there are several tours that we do and encourage medical students to do around the city of Austin, that kind of outline the history of racism in our city, and segregation, and how it's still, visible and prominent today. We stress the influence of historical redlining. You can still see very distinct differences between neighborhoods in Austin, access to resources, access to community resources. We really encourage our medical students and trainees to understand how community and space and history impact someone's health and well-being.
Wonderful. Thank you so much for sharing. Great insight on the city of Austin as well. So let's go into another question, and this is for you, Dr. Powe. What are your thoughts on the discussion of adding social justice and advocacy into the healthcare professional's role, and how does it fit into the discussion of cultural competency?
Well, I believe it's essential, okay? It's absolutely necessary. History and lessons from it need to be told so we don't repeat the atrocities of the past. There has to be advocacy for the individual patient the patients that we take care of, as well as societal advocacy. Here in San Francisco, we also have, vocal and silent advocates. So many physicians are actually silent advocates for their patient in the complex and challenging system of healthcare that we have with regard to access to specialists in medical deserts, drug treatment, expensive medications, and things like even kidney transplantation, for example. So it's absolutely essential to weave in principles of social justice and advocacy.
Wonderful. Thank you so much for sharing. So, Dr. Novick, you recently published an article in the American Journal of Kidney Disease that looked into the patient perspective regarding adverse effects of the unmet health-related social needs. Would you please share a little bit more with us about your study and how it impacts healthcare professionals' approach to cultural competency and social determinants of health in practice?
So this was a study that we did. We interviewed 32 hemodialysis patients who had low socioeconomic status. So we used Medicaid eligibility to define that. So individuals who are eligible for Medicaid. We asked them just quite simply about their environment, about their communities, what resources they had access to, what was their housing situation like, what was their support system, what motivated them, just kind of broad understanding of what their day-to-day experience was like, whether their basic needs were met. And the findings were nothing short of devastating, frankly. What we were able to highlight was dialysis and kidney failure has this effect where it sort of makes you poor and keeps you poor, is one of the quotes that one of the patients said. A lot of people, and we know this nationally, kind of crash into kidney failure. They don't know they have kidney disease. Kidney disease disproportionately affects people who are working lower wage jobs. So they might not have money saved. They might not have as robust a support system. And then, frankly, with rising cost of living and increasing housing prices across the country, but also in Austin, we are seeing that people have to quit their job when they start dialysis. They go on disability, and frankly, the income from disability is just not enough to pay for rent and just basic needs. So a lot of people dip in and out of homelessness right around when they're starting dialysis. So the very act of starting dialysis is traumatic, and then you add on top of that the life stressors that are going along with it. It has a cumulative effect, and what happens is people are paralyzed. They are kind of unable to navigate community resources. They basically, it's sort of a one moment at a time numbing situation where people are terrified of dialysis. They're terrified of dying. They're sort of going to dialysis, coming home, unable to do anything else because of physical and time limitations. And it's just can be a real downward decline from there. And what they also really highlighted was a big discrepancy between what we as dialysis providers talk about and ask about and what they want to talk about and ask about. So, a lot of our conversations and was the same way, are driven by quality metrics. And in the dialysis unit, we have to comment on X, Y, and Z, their phosphorus, their, different things like that. Because we're required to, but as a result, we kind of close off the conversation, and it has a discouraging effect for patients. Basically, they don't bring up the fact that, hey, I haven't eaten in 3 days. Hey, I might lose my house in 2 weeks. So I think that they feel unheard and they feel dismissed. And it's a real shame because there's an opportunity for the dialysis facility to be a real support system. they're there all the time and they get to know the staff, they get to know each other. But basically it's just a missed opportunity for support and interaction. And they highlighted that they have no desire to be dependent on anybody or anything. And most people were independent, and then suddenly, all of a sudden, they lost their independence. And the loss of independence, I think, is the one thing that's associated with the real decline. I find that patients who are still working are still, feel like their life is not as changed. I think they do better. And so there's a connection between the mind and the body that I can't really articulate or explain, but it's just so demoralizing. And I think poverty is just so traumatizing that that's what we're seeing a lot without realizing it. Someone is just frankly traumatized. But they need assistance finding things in their communities. So the recommendations they threw out there were more sort of community health workers or somebody who could help them find the things that are there if they're there. And then the opportunity for peer support, and this has been documented as well in numerous studies, but basically people who are going through kidney failure trust each other the most. And so opportunity to kind of help one another. If somebody doesn't have dinner one day, they could call, I don't know, another dialysis patient, as opposed to relying on something like they're actually less excited to engage in something like Meals on Wheels, again, because they just don't want to feel dependent on another entity. So it really sad findings. I encourage everyone to read it. Really, rich data, I think, from a research standpoint, and just highlights the day-to-day experience of a lot of our individuals.
Wow, great. Thank you so much for sharing. It's always wonderful to kind of get the insight of the patients and what their perspective is on their care and their treatment, and also, what they're going through in their everyday lives. So I think that sounds like a great study for more people to look into. So you mentioned a little bit about, folks crashing into dialysis. And so that kind of gets in, I think, into the screening aspect of things. So Dr. Powe, I would like to move our discussion over to the removal of race from the EGFR calculation. You were at the forefront of this discussion surrounding this modification. And I would like to know, what is the impact of this change on kidney disease diagnosis and care? And also, how has the diagnostic change impacted the topic of cultural competency for healthcare professionals?
Sure. Before I do that, I just want to congratulate Dr. Novick on that wonderful study. Really enlightening to hear patients' own voices. So with regard to the kidney disease diagnostic dilemma that we faced, and particularly in 2021, the American Society of Nephrology and the National Kidney Foundation formed a task force that changed that equation to make it race-free. And there's been profound uptake of that equation in the United States. We know that after a year and a half, 2/3 of laboratories had changed the way that they calculate glomerular filtration rate, from creatinine. Now, when you look at that, that compares to after 8 years, only 50% of facilities in the United States had adopted the original race-free equation. So it was lightning speed that this has been uptake. And it's changed how we diagnose kidney disease for all patients, not just African Americans. It's race-free. It was evidence-based. It included data from minority populations, and it didn't disproportionately, and this is important, affect one group more than another. And many of the approaches that were being used affected one group more than the other. And it's patient-centered. We used an inclusive process that included not only looking at the clinical evidence, but thinking about our values, and we set up attributes of how to evaluate all the considerations that one needed to think about in addressing this change. And we had open forums with all types of groups, from physicians to learners to patients. So yeah, really, it has changed the way that we diagnose kidney disease. And I think importantly, we have a unified approach to this as opposed to different institutions doing this in different ways.
Great, great. Thank you so much for sharing your insight on the equation and how we got to where we are today. Dr. Novick, there have been other discussions about health equity and cultural competency for both patients and healthcare providers. What is missing from the current discussions and trainings and research on this topic? Any thoughts on that?
I do think that what's missing, I will say, my perspective is a little different because I'm in a state that loves to silence these discussions, and it's the moral injury associated with that alone is really terrible. But I would say the one thing that I think has historically been missing, but we're seeing more of, is the impact of trauma and the importance of trauma-informed care. There is a group out of the VA who's really sort of pushing for this, but we're realizing with adverse childhood experiences and lifetime exposure to racism and traumatic events and poverty, how this impacts somebody and their likelihood to develop trauma-related mental health issues as a result of being in the intensive care unit, and and the fact that we are re-traumatizing people whenever we encounter them in the clinic, in the healthcare system, by kind of perpetuating and reminding them of prior traumas. And there is a real potential for healthcare to be kind of a therapeutic space, also with respect to trauma. And right now, we're not taking advantage of that. We're not talking about it and not teaching it. And, I think that really needs to be incorporated into medical education, and it impacts pretty much most patient encounters without us realizing it. So there's also inherited trauma. So the traumatology field uses, these are based on mice, obviously, but have seen the epigenetic changes related to trauma or as a result of trauma are passed down for 14 generations. So we're also seeing the impact of trauma from your ancestors, and how that impacts things like your weight, predisposition to diabetes, obesity, things like that, mental health, addiction, all this stuff is really critical. So I would say that's the one thing we've been trying to push here. There's a trauma-informed care certification course. We're going to have one at the National Kidney Foundation next spring that I encourage all providers to attend. But that's probably the one thing that I think we really need to be talking more about is what is trauma. It's not just going to war. We're now realizing that being in the intensive care unit has the same impact on your brain, your nervous system, your physiology as being in combat, as far as, and things like that. So that's probably the one thing to answer your question.
Thank you so much. Yes, I've heard the comparison of combat to a lot of scenarios, but I don't think I really thought about it from that aspect. So thank you for sharing. Dr. Powell, did you have anything you might want to add here? And if not, I'll move on to our next question.
Oh, I think that's great. Yeah.
Wonderful. So, Dr. Powe, I do have another question here. What can organizations like American Kidney Fund do to support kidney disease healthcare professionals? And how can we keep this discussion going?
Yeah, so we need to keep this at the forefront. For example, the controversy over using race and kidney function brought attention to the huge disparities in kidney disease, not just race in EGFR measurements. So it's helped us to really focus on what I would say are the more powerful determinants of inequities. They include social factors, environmental and genetic factors, even with the APOL1 disease variants that we see in the African American community. It deals with clinical practices and societal policies that conspire to lead to either poor health or poor care for kidney disease patients. So it's caused us to delve into these factors more, including racism in all its dimensions: internalized, interpersonal, and structural racism. One of the things is we know that transplant disparities and referral to nephrology professionals, those disparities existed prior to the race-based equations. So there are other factors and more important forces that are driving them. And so now what we're seeing is attention to those forces that cause health disparities. So I would say that organizations need to develop tools and best practices. I think also, very importantly, as the AKF has done, is to support training of a diverse workforce. Having persons take care of you who are have similar lived experience is really important. And that's been shown in a variety of studies that patients are not only more satisfied, but they're listened to, and they get the treatments that they truly want.
So, thank you so much. Dr. Novick, same question for you. Are there any additional ways we can keep this conversation going?
I think I really want to say that I love the AKF's social, I don't know the specific term, but the social needs fund is what we call it at our dialysis facilities, where people can sort of apply for just a little bit of money to help ends meet at the end of the month. I think that we desperately need more programs like that because of what I described earlier. A lot of people are not aware of their kidney disease or what kidney failure will mean. And sadly, I don't know that changing the GFR equation will change that. And people, frankly, just at the end of the day, need a little extra money to afford their medications and some groceries. And programs like the AKF's Social Need Fund are really, really important. And I think, if we could focus more on little things like that, it's very tangible, accessible to patients, and makes a big difference. It could mean the difference between somebody keeping their home versus, having to sleep on a bench outside of dialysis, so things like that are just really, really critical.
Thank you so much. We appreciate that. We try to make sure that we're doing the most that we can for our patients through our financial assistance programs, such as our safety net program, which I think you're referring to. So thank you so much for mentioning those. So thank you to both of you for such a wonderful discussion today. One thing I want to do is give each of you a moment just for any closing thoughts on today's topic of cultural competency, and any final thoughts for healthcare professionals caring for patients with kidney disease. Dr. Novick, I'll start with you, and then Dr. Powe.
Yeah, Dr. Powe spoke about the importance of advocacy earlier. And I just want to kind of provide the perspective of someone who lives in a state where that's not celebrated. And it's just extremely demeaning to be in a state where politics and policies greatly impact how I can practice medicine. Working at an FQHC, I can see individuals, but I can't actually get them medication most of the time because of cost and insurance and it's things like that. And it's mainly based on their citizenship. I also can't give them access to standard treatment for kidney failure. So they cannot receive consistently standard dialysis, definitely not kidney transplant, regularly. There are programs that are very helpful, but and AKF provides one of those, but it's still, there are people who fall through the cracks and it's devastating as a physician. The pediatricians in our state are also experiencing this. The OBGYNs are experiencing this, but people don't realize it also affects nephrology. And it truly is demoralizing. And as a provider, I think a lot of people do not want to practice in states like Texas because we can't practice the way we were trained. And there are great programs that, like, for example, the Texas Medical Association has kind of a state advocacy day once a month where physicians can go and kind of talk to congressmen and women about how policies are affecting the medical world. And there are a lot of programs like that, but it's still not enough. And I think awareness of that and the potential for that to really make disparities for kidney disease much, much worse if providers don't come, if we can't, we're already very strapped down here. There's a huge need. A lot of people just don't have access to care, and it's really, really hard. And I think that it's potentially going to get worse if we can't support providers, secure them from keep them from losing their jobs if they speak up, that kind of thing. So it's a different situation in these states like Texas. It's really, really hard.
Thank you for sharing. Dr. Powe, any final thoughts from you as well?
Yes, I'd like to say that, this is an ongoing and learning process for our healthcare systems, whether that's in primary care treatment of patients with kidney disease or in specialty nephrology care. The pursuit of justice, of health justice, didn't stop with the passage of Medicare or Medicaid or civil rights legislation in the 1960s. It shouldn't stop now, with the EGFR controversies. We continue to refine the evidence and the strategies and approaches that need to be done. So we need to keep our attention on eliminating inequities in kidney failure outcomes and access to care. It has been my desire that the advocates for removing race in kidney function estimation stay in this game to eliminate health disparities, keep up the momentum to address the important factors that compromise equitable care.
Great. Thank you. Thank you so much. And thank you both for such a great discussion today. So with that, for more information about AKF's professional resources, please visit our website, which is on the screen right here, kidneyfund.org. And if there are any topics that you are interested in to help support your patient care, please share it with us at professionaleducation@kidneyfund.org. Thank you to both Dr. Powe and Dr. Novick for joining us today. And once again, thank you to the Kidney Health for All sponsors for supporting today's webinar. And thank you for joining us. And we hope to see you again soon.
Okay.
All right.
Thank you, everybody.